Okay, round two. Kinase inhibitors. This is the best approach for patients with relapsed refractory CLL. Okay. Now, just a little biology. You've seen variants of this. You've got a B-cell receptor. When it's constitutively activated or through some other mechanism, it stimulates a number of pathways inside the B-cell. The SYK pathway, the PI3 kinase, and the BTK are the ones that have been most frequently targeted. And the first drug to be approved for targeting one of these pathways, and these pathways lead to the proliferation and the resistance of the leukemia cells to therapy, has been Ibrutinib. This is a highly potent, specific BTK inhibitor. It's given once a day by mouth, unlike what you do to people. And I showed these data before. It was approved in part on the basis of the RESONATE trial of once-a-day oral drug versus ofatumumab intravenously. And I showed these data already, 63 versus 4% response rate, or 85 versus 23% response rate. But these are mostly partial responses, some partial responses with lymphocytosis, and it's rare to get a complete remission. But does it really matter if you're doing just fine for years taking a couple of pills a day? And the progression-free survival with ofatumumab of 8 months versus not reached shows that this is significantly better than what is the currently available approved standard therapy for relapsed CLL. And the survival, again, is significantly longer with a couple of zeros before the 4.9. And if you look at the toxicity, just grades 3 and 4, there really isn't much there. There's a little bit of neutropenia, but it's about the same in both arms and not much else. I think it's a little less than you do to people, right? Just a little? Yeah, okay, thank you. We did talk about the atrial fibrillation. It was 10 patients versus 1, but only 1 patient had their drug discontinued because of this. There were some more bleeding events, but mostly were grades 1, a nosebleed. I had a patient with a conjunctival hemorrhage, a few spontaneous bruising. In general, not bad. I'll forget that I got up to the microphone and said what I did before. And only 1 patient discontinued Ibrutinib due to a bleeding event, and that was my patient that I sent to Ohio State. You know how bad the 17p deleted patients are. Well, the RESONATE 17 was the study in the subgroup of patients with 17p deletion. And what do you get here? You get an 83% response rate with 17% partial remissions, lymphocytosis, and even a patient got a complete remission. This is what you get with standard therapy. It looks like the slopes at Snowbird. This is the 17p with a median event-free survival of less than 6 months. And here, you've got a progression-free survival out here at about 80% with a median of a year follow-up, but more data are coming out. And yes, it trickles down a little bit, but this is much better than we've ever seen with any other agent. And the overall survival, 84%. Much better than chemotherapy. The other drug is Idelalisib. This is the PI3 kinase inhibitor, delta isoform specific. And Dr. Furman, I was surprised he didn't mention it because he left already. He's the first author on our paper that was published in the New England Journal. The patients from the Idelalisib pivotal trial were sick patients. And you have to remember, this is a different population than those who got approved for Ibrutinib. They had to have progressed in less than 2 years from their last treatment. They had to have had prior anti-CD20 or at least 2 prior regimens and could not receive cytotoxic therapy because of bad kidneys. Their marrow didn't come back. They had major comorbidities. They were sick patients. Nonetheless, 77% response rate. It was Rituximab, placebo Rituximab, 77 versus 15%. Even advanced stage, same thing. Unmutated patients, same thing. 17p deletion, 82% response rate. Every subset was better than the placebo Rituximab group. And if you look at the progression-free survival, 19.4 versus 7 months. And the overall survival, this is all patients, this is unmutated, highly significant. The toxicity, the big problem toxicity is colitis. And it occurred in about 16% grade 3 or worse. Nothing else is really that notable. There are some pneumonias, but this is CLL. There's 2 forms of colitis, an early form, which is generally readily reversible with anti-diarrheal medicines, and the late form, which is a real colitis and can be a real problem. And some patients have elevations in their liver enzymes, but generally not grade 3 or worse, and they tend to be reversible. And now we have a whole new generation of these drugs. We have ACP-196, which we're studying extensively at our institution. We haven't seen any bleeding at all. We haven't seen any diarrhea at all. We have a few headaches, but they're not bad. The Ono drug you heard about also. The other one I won't mention because is not being developed. And there are numerous PI3 kinase. We're studying 9901 from Gilead, which is another delta isoform inhibitor. There's Idelalisib, formerly IPI-145. There is the TG Therapeutics, and I finally learned what TG means, but I won't tell you. And Copanlisib, which I don't think is going anywhere because these are oral, this is intravenous, and why would you do that to somebody? But I'll show you some data with the Ono compound. This is the other BTK inhibitor because they're interesting. These are presented at ASH. This waterfall plot shows that about every patient had at least a partial response. And the yellow bars are patients with 17p deletion. So they do quite well. The median tumor reduction was 80%. They had a CR, 89% in the 17ps. These are pills, character. Come on. Not that transplant stuff, but the high-dose whatever, GVH disease. As far as toxicities go, grade 3, 4, really nothing. At the higher dose levels, really nothing. Idelalisib or IPI-145, we got so many of these out there now. Again, here's a waterfall plot showing that the majority of patients got at least a PR, and very few progressed. Adverse effects from this drug, grade 3 and 4, some neutropenia, but pretty much some pneumonias, pretty much nothing else. And here's the TG drug, TGR-1202. And again, the median nodal reduction, 70%. Innocuous drugs. And it's being combined with Ibrutinib. And what are you getting? You're getting response rates in CLL of almost 90%. High-risk CLL, 95%. This is without the aggravation of transplant. So beware. You're going to hear more about CART-19 therapy. This is the hot thing. Every patient wants to know about CART-19 therapy. You're talking about it? You're talking about it. I'm not going to say much about it, other than the data are limited. Yes, it works, but patients develop prolonged hypogammaglobulinemia, a cytokine release syndrome, macrophage activation syndrome, delayed tumor lysis syndrome. You need a renal unit nearby. You need an intensive care unit nearby. What I've been talking about are pills. Take 2, 3 pills once a day, twice a day. You're doing just fine. Thank you very much. Yes, you've got to take them indefinitely, but it's none of this stuff. Oh, ABT 199, you hear a lot about this. But, oh, this study was suspended, and that study was suspended, and that study was suspended because of tumor lysis syndrome. I didn't show you any tumor lysis syndrome with all those eye drugs I showed you for, and the TG drug, of course. You can't forget TG drug. And transplant. Mortality, GVH disease, and not that it's a select group of patients or anything. Young patients, healthy patients, patients who can tolerate that sort of business you do to them. You're a nice guy, though, basically a nice guy. But you just do this to people for a living. So, if I were to vote for transplant or what you're going to hear next, those dastardly forms of therapy, what I would vote for are the kind ACEs. Thank you.